Okay, good afternoon, everyone, and welcome to the 45th seminar of the International Interdisciplinary PhD in Progress seminar series, Phase 3, organized by the Global South Network. I'd like to start by thanking the organizer of this fantastic weekly seminar series, Dr. Noman Riyad, lecturer in law at Leicester Law School, and the founder and convener of the Global South Network. I'm Dr. Hanieh Yagootkar, and I will be chairing today's session. I'm a senior lecturer in precision health and lead the precision health group at the University of Lincoln. My team employs advanced statistical methods, machine learning, artificial intelligence, and large-scale genetic studies, alongside human big data to identify causal biomarkers for various diseases, including genetic and biochemical markers. Our ultimate aim is to develop personalized prediction models and uncover the underlying mechanisms of complex diseases, all in support of personalized health. A key focus of our research is understanding that not everyone with obesity shares the same risks for metabolic and cardiovascular diseases, including diabetes. We investigate how fat is distributed in key internal organs, such as the liver, pancreas, and muscles, using MRI scans to help determine an individual's risk for these conditions. I'm joined today by two discussants. Our first discussant is Dr. Ashra Khanum, a senior research fellow in health services research at Swansea University's Faculty of Medicine, Health and Life Sciences. She's also part of Prime Centre Wales, which focuses on primary and emergency care research and is funded by Health and Care Research Wales. Ashra's work with asylum seekers and refugees contributes to the British Medical Association's Refugee and Asylum Seeker Patient Health Toolkit. She also played a key role in the Welsh Government's Health and Social Care Committee report, which is titled Connecting the Dots, Tackling Mental Health Inequalities in Wales, published in December 2022. Our second discussant is Dr. Hanieh Atherley, an associate professor and director of student research for the Community Medicine and Global Health program at Ross University School of Medicine, Barbados. Hanieh completed her PhD through a joint scholarship from Western Sydney University and Maastricht University. She has published over 15 peer-reviewed articles and reviews for international journals, including Medical Education, Transfusion Medicine, and Advances in Health Science Education. Her work includes research on barriers to insulin therapy in people with type 2 diabetes in the Caribbean island of Barbados. We also have Chandini Subramaniam, a PhD candidate at the University of Leicester's School of Population and Health Sciences, as the peer commentator for today's session. Chandini is in the final year of her PhD with the Social Science, Applied Healthcare and Improvement Research Group. She holds 2 master's degrees, one in forensic psychology and another in sport and exercise sciences. She brings a wealth of experience from international teaching, special needs education, sport coaching, and working on hospital wards. Last but not the least, our guest speaker for today is Priscilla Katapa, a PhD student at the Leicester Diabetes Centre, part of the Department of Population Health Sciences at the University of Leicester. Priscilla is a registered nurse with over 20 years of experience in healthcare and public health. Her passion lies in promoting health equity and improving patient outcomes. Her PhD project focuses on the role of community health champions in supporting insulin therapy initiation among people with type 2 diabetes from ethnic minority populations. Priscilla will now present her project titled Barriers to Insulin Initiation Therapy Among People with Type 2 Diabetes from Ethnic Minority Population, a Mixed Methods Systematic Literature Review. Priscilla, you have 30 to 35 minutes for your presentation. I will indicate it if you go more than 32 minutes. And we will follow by 7 minutes for comments or questions from our discussants and peer commentator, and a further 15 minutes for questions from attendees. Priscilla, the floor is yours.
Thank you very much for having me, and thank you for the opportunity, Nauman, to come here today. So my PhD project is funded by the NIHR East Midlands in collaboration with the University of Leicester. And my supervisors are Professor Pratik Chaudhary, Dr. Michelle Haj Constantinou, and Professor Kamlesh Kunti. So my topic of discussion today is a review titled Barriers to Insulin Therapy Among People with Type 2 Diabetes from Ethnic Minority Populations. So a mixed method systematic literature review. So the aim of the presentation is to share findings of my review on barriers to insulin therapy, focusing on ethnic minority populations specifically. The next one. So I've changed the slides a bit, so I'll just talk through what I have on my slides because I've added one more slide. Just a few definitions about type 2 diabetes. So type 2 diabetes is a chronic metabolic disorder characterized by insulin resistance, relative insulin deficiency, leading to persistent hyperglycemia. And it results from a complex interplay of genetic, environmental, and lifestyle factors, and is associated with complications affecting cardiovascular, renal, the nervous system, as well as the eyes. Unlike type 1 diabetes, type 2 diabetes is not, in type 2 diabetes, insulin is not completely absent. However, the body has inability to effectively metabolize glucose levels. Now, the definition of ethnic minorities refers to a group of individuals who differ from the majority population in terms of cultural, linguistic, and racial and national identity. So the global diabetes crisis. Type 2 diabetes is a serious, growing public health concern affecting 482.2 million people worldwide, and the International Diabetes Federation predicts that by 2045, 783 million people will be living with this disease. And a considerable proportion of the prevalence comes from lower to middle income countries. In the United Kingdom, type 2 diabetes affects 95% of the 4.4 million individuals with diabetes, with an estimated 6.4 million at least risk of developing the disease. And we know that type 2 diabetes from literature disproportionately affects certain ethnic minority groups, especially in the UK. And the risk of developing type 2 diabetes in these populations is 2 to 4 times higher in people from the South Asian, Black African backgrounds, and the white populations and non-white populations. Additionally, these people tend to develop diabetes at 10 to 12 years younger than other ethnic groups groups. It is a significant contributor to the global burden and the local burden of disease, leading to increased morbidity and mortality. So I have another slide which I haven't included there yet. So what is the burden on type 2 diabetes on the healthcare system? A recent analysis that was conducted highlighted that diabetes treatment and management, and that is in the UK, are a considerable cost burden to the NHS healthcare system, accounting for about 6% of the UK budget. And an updated cost of illness analysis commissioned by Diabetes UK, carried out by York Health Economics Consortiums at the University of York, estimates that type 1, type 2 diabetes and gestational diabetes together cost the UK 14 billion in 2021-2022. Over 6 billion of this was used to treat diabetes-related complications, which are mostly preventable. Of the 10.7 billion in direct costs, the researchers found that approximately 4.4 billion was spent covering routine diabetes care, which included diagnosis, GP visits, nurse appointments, eye screening, blood tests, medications, diabetes technology, education, and support programs and specialist diabetes teams. And then the remainder of the NHS costs were spent on treating complications of diabetes. Indirect costs such as productivity loss from absence from work or death are estimated at 3.3 billion. The reason for conducting the systematic review was while previous systematic reviews have focused on the general barriers to insulin therapy, they did not apply ethnicity and cultural emphasis to their analysis. To address this gap, our mixed methods review aimed to explore in depth how ethnicity influenced barriers to insulin therapy among people with type 2 diabetes. So there were two main objectives for the systematic literature review, as well as added that was a methodology. So the first objective was to identify key barriers to insulin initiation in ethnic minority populations. The second objective was to explore how cultural and ethnic factors contributed to these barriers. And the methodology that was used was a mixed method systematic review using a convergent segregated synthesis of quantitative and qualitative data. This approach integrates quantitative and qualitative data in systematic reviews. So in this method, quantitative and qualitative data are analyzed independently using appropriate methodologies. That is thematic synthesis for the qualitative data and narrative synthesis for the quantitative data. The separate syntheses are then contrasted and compared and integrated to provide a comprehensive understanding of the research question. So the methods overview. The systematic review protocol followed the Joanna Briggs Institute for systematic mixed method systematic literature review, and the critical appraisal checklists were used from the Joanna Briggs, as well as the PRISMA guidelines. So a comprehensive search strategy was conducted since inception in November 2021 up to February, repeated again in February 2024 in various databases, including Medline, CINAHL, EBSCO, Scopus, PsychoInfo, and Web of Science, and no language filters were applied using predetermined search terms such as type 2 diabetes, therapeutic inertia, insulin initiation, patient compliance, and barriers to insulin therapy. The inclusion criteria was adults with type 2 diabetes over the age of 18 years of age from an ethnic minority background and have been offered insulin and have either accepted or declined it. Healthcare professionals with experiences of managing type 2 diabetes in ethnic minority populations. And studies that also explored barriers and facilitators to insulin therapy in ethnic minority populations. Studies that looked at insulin initiation in ethnic minority populations, qualitative studies, cross-sectional studies, and observational studies. The exclusion criteria was studies that were conducted in children under the age of 18, type 1 diabetes, other forms of diabetes, which is more the latent onset type 2 diabetes and the likes, and also gestational diabetes. All those studies were excluded from the inclusion, and reviews as well as systematic reviews. So this is a PRISMA flow chart showing how the studies were identified from various databases and registers. So from the various databases that I mentioned earlier, 16,463 studies were identified, after which duplicate records were removed. A total number of 6,118 duplicate records were removed, and 10,000 records were screened, and 10,013 records were excluded. 332 studies were sought for retrieval, and then 332 studies were assessed for eligibility. 13 studies were eventually included in the study. The reports that were excluded with various reasons were 268. It's important to note that the number of studies excluded were due to irrelevant study designs, lack of focus on ethnic minority populations, or did not address barriers to insulin therapy. There is an overview of the studies that were included in the review. The studies included in the review originated from 8 countries: Australia, UK, South Africa, India, Malaysia, USA, Hong Kong, and Congo. So the 13 studies, 8 of them were qualitative studies and 5 of them were cross-sectional studies. The various ethnicities represented were Black African, South Asian, Malay, and Chinese. The mean age of the participants ranged from 49 to 67 years, with diabetes duration varying between 12 months and 10 years. So the key barriers to insulin therapy using from the cross-sectional studies. So like I said from the start, it was a mixed methods systematic review. A convergent segregated methodology was employed. So the narrative synthesis was employed for the quantitative studies due to the heterogeneity in the study designs, the outcomes and measures which precluded a meta-analysis. So a narrative synthesis allowed for the systematic collation and description of findings, enabling the identification of recurring patterns, themes, and gaps in the data. It is particularly suitable when contextual factors such as cultural and healthcare system differences need to be highlighted. So this narrative synthesis complemented qualitative findings by describing how quantitative results align or differ from the thematic findings. The approach strengthened the overall synthesis in the mixed methods review. So 4 quantitative barriers were identified in the studies that were included. The first of them was fear of injection, which was a consistent barrier where 68 to 80% of the participants reported fear of injections. The second barrier identified was financial constraints, high cost of insulin, and bearing in mind that the studies originated from low-income countries, so its insulin cost was a big factor in the barriers to insulin therapy in terms of people accessing insulin, being able to afford insulin, because most of the systems do not have health insurance like our NHS system, where most of the people can access these medications much easier. Perceived limitations, that was around concerns about insulin's restricting daily activities of living. People cited things like going out, having family gatherings, how do they plan if they have meals, and things like that. Just factoring in insulin into their daily activities was something that was a challenge. There was also a misconception that insulin is only for severe cases, and severe cases meaning you only get insulin at the end of your diabetes journey, not at the beginning. So if you are prescribed insulin, it meant that your diabetes had deteriorated. These findings reflect the broader barriers that have been highlighted in literature elsewhere about insulin therapy. The key barriers identified or developed from the qualitative studies. A thematic synthesis was approached, and approach was used, and data was analyzed using NVivo, a qualitative data analysis software. Thematic synthesis was employed for the qualitative study. Reason was to systematically extract, categorize, and interpret recurring themes, generating higher order analytical themes on barriers to insulin therapy. So this thematic synthesis process has got 4 stages. So the first stage started with coding the data from the qualitative studies, identifying key concepts and participants' experiences. And the second phase looked at developing descriptive themes. So the codes that were identified or developed from the first stage were grouped into broader descriptive themes. And the third one was generating analytical themes, and the themes were interpreted to create analytical themes. And the final stage was a final synthesis, which was used to identify patterns from the coded descriptive themes and provide insights of what the barriers were. So the qualitative findings developed 4 themes. The first theme was psychological factors, and these factors included fear of injections, fear of pain, lack of confidence to self-inject. And then there was cultural or social stigma, negative cultural beliefs around insulin use, adherence challenges, difficulties in integrating insulin therapy into daily routines. And there was also knowledge gaps. Many patients lacked sufficient understanding of insulin therapy, and the knowledge gaps were not only from the patient side, but also the healthcare professionals also lack the skills on how to prescribe insulin and give education to the patients about how insulin is supposed to be administered. So the next slide, which you don't have there, has got, I have it here, qualitative findings, some quotes from the psychological barriers. So for example, one of the quotes from the psychological barriers from the descriptive theme called refusal of insulin due to fear-related reasons. One patient stated, "I'm scared of the needle. You know, the poking itself is painful. Using needle, you poke yourself, is very painful." So that's a psychological barrier, fear of pain to insulin. And then social stigma, there was a quote here about there was no way I could go on insulin because my husband would divorce me if I go on insulin. Because it just indicates that there's that social stigma and also the fear of not being accepted in the society. The other quote from the medication adherence was, "It was hard to get into a habit with taking my medication. It was just like medicine was controlling me. I was always on a time frame, trying to be conscious of what time it is. Family or work roles sometimes interfered with medication taking." The knowledge gaps, one interesting quote came from a medical officer who stated, "For me, insulin was not an option. It frightened me because I had no idea how to determine the correct dose for the patient." So how were the findings from the quantitative and the qualitative data integrated? So the qualitative and quantitative data findings in this review were mostly complementary and supportive of each other. This was specifically relevant to the findings on the lack of self-confidence in injection, misconception, fear of complications, and belief in limitations to daily activities of living. and financial cost. So although social stigma was a strong factor in qualitative studies, it was weak in the quantitative studies because only one study explored this barrier. Therefore, it was not included in the synthesis. So for the psychological factors such as anxiety around self-injection were central themes in both the qualitative and the quantitative data. The findings complemented each other to form a more comprehensive picture of the barriers. The social stigma concerns were around, from the qualitative study, were around being conceived as seriously ill or different when using insulin therapy. Other patients mentioned how faith helped them to cope with their conditions. Others struggled with culturally imposed beliefs. It's also important from the social cultural aspect to note that the family and the community support or lack thereof plays a role in patients' willingness to initiate insulin in these communities. So what are the implications for clinical practice? There is need for culturally tailored interventions, need for diabetes education programs that address cultural beliefs, fears, and misconceptions about insulin therapy. And the misconceptions about insulin therapy, some of them originate from lack of knowledge and understanding about diabetes in general, as well as insulin therapy. There's also need to advocate for improved healthcare provider training, so that they improve their patient-provider communication and offer culturally sensitive care, as well as cultural awareness and cultural sensitivity when dealing with ethnic minority populations. There's also need for enhanced access to insulin therapy, and this is applicable not in the UK context, applicable in other contexts where healthcare services are not funded by the government, but they're privately funded, particularly in low-income settings, to reduce financial barriers and also improve health outcomes for people with type 2 diabetes and reduce the burden on morbidity and mortality for people living with type 2 diabetes from ethnic minority populations. The implications for future research. There's need for more. Obviously, these studies were done outside the UK context. And so there is need for more comparable studies that are needed to compare barriers across different ethnic groups within and across healthcare systems. And also research is needed on the effectiveness of culturally tailored diabetes education and healthcare interventions. A call for research to further explore how ethnicity specifically influences insulin therapy barriers, because this review did not really find how ethnicity influences those barriers to insulin therapy, because ethnicity was not an outcome that was addressed in the studies that were included in the review. The strengths of this systematic review, strengths and limitations. So the strengths were that this was a mixed methods approach review, provided both quantitative data and in-depth qualitative insights. The review is one of the first to focus on ethnic minority populations in this context. The limitations are that some studies had small sample sizes and many were conducted outside the UK, which limited the generalizability of the findings. There's also biases in self-reported data, potential social desirability or recall biases. The high proportion of female participants in the studies could have influenced the findings. So the call to action, conclusion and call to action. This review highlights the psychological, cultural, and systemic barriers faced by ethnic minorities when initiating insulin therapy. And this was across many settings from the studies that were included. And the call to action is to encourage culturally sensitive healthcare practices and services and policies that address these barriers. The other thing is to also urge for more research into ethnic-specific barriers and tailor interventions to improve insulin therapy initiation in ethnic minority populations. So thank you very much for listening, and I'm happy to hear your feedback.
Thank you. That was great. So I think the timing was very good as well. Well done. So we start from questions or comments from our discussants first, and then we can go around and see if anyone has any questions or comments for you. Can I start with Ashra, please? I don't know, Ashra, if you are here.
Yep. Yeah.
Oh, yeah.
I'm here. Okay, thank you very much for that presentation. It was very clear and well explained. I was just wondered from your findings, what sort of systematic issue or systemic barriers you identified?
So the systemic barriers that I identified, obviously because the studies were done in low-income countries, the systemic barriers were issues with supply of insulin supplies themselves, and also healthcare professionals did not have the skills or the education or the guidelines that they could really look at and say, okay, this is how I'm going to start this insulin therapy. So that was found to be lacking in the studies that I had included in the review.
Okay, thank you.
So the barriers were both healthcare provider and patient, more on the healthcare provider. So in terms of supply, financing of supplies of insulin, the government funding diabetes clinics, so to say, and education for their healthcare staff.
Thank you very much for that explanation.
Thank you.
Great. Okay. Hanieh, do you have any questions or comments?
Hi, Priscilla. Thank you so much for that presentation. It was really insightful. I guess my question would be towards like next steps. Like, given the barriers that identified, what stakeholders do we think are critical towards creating or co-designing these culturally targeted interventions that would address some of the barriers that were described?
Thank you. So this is objective one of my PhD. So the second objective was conducting a qualitative study to explore experiences from people living with type 2 diabetes who've been offered insulin therapy and healthcare professionals as well. And then following that, develop an intervention using community champions to support the initiation of insulin therapy in people with type 2 diabetes. So those are the next steps. Yeah. Thank you.
Yeah, great answer. And I look forward to more of that work. Thank you.
Thank you.
Right. Okay. Is there any question from our attendees? No question? Okay. Chandini, do you have any question or comment? Oh, sorry. Let's go to Rona first. Sorry, Chandini. Let's go to Rona.
Sorry,
I
just realised the camera switched off on the machine. Thank you very much for a very interesting presentation. I've not got a medical background at all, but I have worked with a lot of people dealing with diabetes and some of the challenges, particularly in East Asia and also in Pacific Island states. And I was just wondering what you think was the key way forward from the material you've already researched, because it's very interesting, a lot of the facts and figures and a lot of the data you have. But I wondered what would be maybe one thing that you think could make a difference?
I think the one thing that would make a difference is education, and education that is brought to the level of the people, education that is simplified for people to understand first of all, what is type 2 diabetes, how does it come about, and also the role of insulin in type 2 diabetes management, that insulin does not come at the end of the road, but those discussions need to be had at the start of the diagnosis, like, okay, it's part of the treatment. When we get to this stage, you might need insulin, but it's just education and breaking down those myths about insulin therapy. Yeah.
Okay, thank you.
Thank you.
Great, Chandani, sorry, we can go back to you.
No, thank you so much. That was really interesting. I have kind of, I guess, two thoughts or questions. I think my first one is, so you mentioned the cultural and sort of social stigma that comes about from the therapy. But it's interesting that you mentioned that because diabetes is considered like a physical illness. So what do you think are the reasons for, because there's a lot of stigma, mental illnesses, but not. So it's interesting that that finding came out. So like, what would your kind of opinion be on why there's that cultural stigma about that?
So thank you, Chadney. So the cultural stigma from the studies that I came across and included, and some that were not included, in terms of like the South Asian population, if a young person who's not married yet has got type 2 diabetes, it really impacts on their potential life partner, because they are looked at as being sickly, and they would not really make a good wife or a good husband. So those are the stigmas that are associated with. And then the other stigma is, if you get type 2 diabetes, it's your fault. You didn't look after yourself. That's why you've got type 2 diabetes. So there's that kind of, a culture of blame. And actually, I'm also finding that from the qualitative study, that there's a culture of blame. If you get diabetes, it's your fault because you're eating too much, and that's why you've got that. So there's that kind of perception about type 2 diabetes causing that stigma. And the injection bit, and I think injection bit for the women is exposing themselves in public to give injection. If they're from a Muslim background or any other religious background where they don't expose their bodies so much in public, that would be an issue if they're going out to give insulin, or just having to excuse yourself to go to the toilet and give insulin. In other circumstances, you are looked at as a junkie, or maybe you are on drugs if you're giving insulin in public. Yeah.
Thank you. That's really interesting. And I think my second question is, so you mentioned that actually your findings might not necessarily apply to UK context, but I think they still do, because we have these very insular communities, that don't have these about these stigmas that you just mentioned. So I think actually there's more of a thought than a question, but actually it'd be good to start here, and then apply these learnings, how they work in these communities here, because they've still got the education and campaigns, health campaigns, whatever. But we've got the funding here as well. So actually it does still really apply here. So I wouldn't say, I don't think you should say that it doesn't apply here, because it does, if that makes sense.
Thank you.
Great, thank you. Maybe I can ask a question. Did you find any difference in, for example, what are your findings in men and women? Did you analyze men and women separately?
No, that's not something I did. I did not conduct a separate analysis for men and women. Like I said, predominantly the women were the ones that participated in the study. And it is common, again, I think, from the qualitative aspect and in ethnic minority populations, to find that women are the ones who come forward. I mean, in the context in which the studies were done, maybe because women were on lower income, they were not earning, they were at home, so they had the time to participate in the qualitative studies. But no, I did not do a separate analysis for the men and women. That would be something interesting probably to look back at.
Yeah, I think it would be interesting to see, and also study ethnic groups individually, and then compare, see if there's any any difference. Excellent. I think Ashra has a question or a comment. Ashra.
Yeah, just a quick question. The studies that you report on, what approaches, recruitment approaches did they use to recruit participants to the study? So that might be useful learning for us as well here in the UK.
So the qualitative studies, most of them used purposeful sampling, if I can recall. And then there was snowballing as well. And some of them were conducted in diabetes clinics. So patients were approached as they came to the diabetes clinic and told about the study. So known to the researchers already, so to say. So they approached them. So there was purposeful sampling, snowballing, and just from the clinic databases, clinic lists.
Because one of the study I've been just recently completed, we really struggled to identify people, ethnic minorities, through the GP records in the UK. Well, in Wales, basically, because they couldn't identify them in the system.
Yeah, I faced the same problem with my qualitative study. It was a big challenge identifying them from the clinic list and the GP clinic list as well. Even social media was a challenge, just getting participants from there. Yeah. So, but eventually there was a list of patients who had agreed to be contacted for future research, and that helped to drive the numbers up. But just getting them, try maybe Diabetes UK. I put adverts through Diabetes UK and Twitter. That was helpful as well. But then again, another challenge with, I don't know if I can say this in this context, with what I found from my current study with ethnic minorities was getting remunerated is very, very important. So you have to include that in your funding to pay them for their time. So as soon as I said there's no payment, then people just dropped off. They were not interested anymore. So that's something to remember and have in mind.
Great. So there's a question in the chat from Gifty. How did the study deal with the stigma and the cultural challenges identified?
So sorry, what? How did they study the review?
How did the study deal with the stigma and the cultural challenges identified?
Okay. So the systematic review built onto the qualitative study. It was feeding into the qualitative study. So the stigma and what was the other question? Stigma and
the cultural challenges.
And the cultural challenges. So that was built into the qualitative study, the topic guide for the qualitative study, to be able to compare whether what we found from the review is the same with what is happening on the ground. And I'm still analyzing the data to see whether these two agree or not.
Okay. Chandini.
Sorry, just on that last point that Ashra mentioned, if you're better off just sort of going out into the community yourself. Like, I'm a big advocate for, going out into community and targeting community leaders or whoever. But also, if you talk to the carers, they're more likely to say, oh, he's got XYZ or she's got XYZ. And identify the carer and go through them. But yeah, that's just what I've learned from doing my research. So I hope that's helpful.
Okay, maybe I can ask one more question. How do you propose addressing the financial barriers? Did you identify any financial barriers, and how do you propose to address these barriers given the relevance in healthcare system with different funding models?
That's a difficult one, I think, because of the context in which it's happening. Probably governments need to look into supporting people with type 2 diabetes, like giving them concessions for the healthcare in terms of insulin should be added to critical medications. I mean, in this day and age, people should not die because they don't have insulin to inject themselves with. But it's a country-specific thing, and what the priorities of those countries are. Certainly for the UK, we know that it's a priority, but for the developing world, I think it's something to push for. Like every government has to bring it on board. Even just a simple type 2 diabetes medication like metformin sometimes is not even available in this context. So even just starting with those simple things, funding them. Yeah.
Excellent. Is there any other question? Ashra, yes, please.
Just a quick question, sorry. It might come up in your qualitative data as well, but what we did find was people were deciding whether to take metformin or not, and the dosage as well, because there was a lot of misunderstanding around the purpose of the medication and what it would lead to in the future. So there's quite a lot to explore in this field. So yeah, wish you well with your PhD and future work.
Thank you very much.
Thank you very much, Ashra. Okay, thank you, Priscilla,
Thank you very much.
For an excellent presentation. It has truly enhanced our understanding of the barriers to insulin initiation therapy among people with type 2 diabetes from ethnic minority populations. I'd also like to thank Dr. Ashra, Dr. Hanieh, and Chandini for their insightful comments and contributions. And of course, a big thank you to everyone who attended today's session. The Global South Network International PhD in Progress series warmly welcomes PhD students from any discipline and any part of the world to share their projects and benefit from interdisciplinary feedback. If you are interested in presenting your work or joining future sessions, please get in touch with Dr. Nauman Riyad, founder of the Global South Network. His email is leicsgsn@gmail.com, or you can use Global South Network at leicester.ac.uk. Next week, at the same time, we'll be welcoming our guest speaker, Hafsa Saeed Shah, a PhD candidate from the Humanities and Social Sciences Department at the Indian Institute of Technology, Bombay, India. Hafsa will present their project titled Organizing the Sheikh Sanitation Workers in Srinagar from the Politics of Dignity to Pasmanda Activism. On 4 December 2024 from 3 to 4 p.m. UK time. Until then, take care of yourself and have a wonderful day. See you next week.
Thank you. Thank you.
Thank you. Bye.
Bye.
Bye.